Hello everyone, my name is Emily Umbers. I'm with AIDN, the Australian International Development Network. Before we start today, I would like to acknowledge our traditional landowners from the various places we are all tuning in from. I am on the lands of the Wurundjeri people of the Kulin Nation. We pay our respects to all First Nations people, past, present and emerging, for their generosity and custodianship of country. Today's session is the double burden of pneumonia and COVID-19 and the urgency of closing the oxygen access gap. Our session will be facilitated by Anuba Rawat, Projects Director at the DAC Foundation, and on our panel we're really thrilled to have Leith Greenslade from the Every Breath Counts Coalition, Julius Mbeya, Co-CEO of Luala, Marnie Rickards, also from the DAC Foundation, and Roger Russell from Free02 Foundation. We've got much to discuss today, so we're going to jump right in. Bios of our panelists will be in the chat function. Thanks for joining us, and it's over to you, Anuba.
Thanks, Emily, and a very warm welcome to you all joining us today. November 12th is World Pneumonia Day and was established in 2009 to bring the world's attention to a disease known as the silent killer, responsible for being the single largest infectious disease killer of adults and children every year. COVID-19 has brought the world's attention to this deadly disease, but also critically highlighted the huge gaps that countries and health systems face in tackling this disease. I'm honored to be hosting an incredible panel of experts today to help us unpack and understand some of these issues and to share with us some of the things that are being done and what else needs to be done to address the gap. So to start us off, I thought it would be great to ask all of the panelists a question to get us going. And what I wanted to ask each of you is this: what has been that pivotal moment for you where you've stood back and recognized the urgency around pneumonia as a disease and the huge gap in access to oxygen therapy? So to start us off, good morning, Julius. Thank you for joining us so early this morning. Since it's the first thing in the morning for you, I think we'll start off with you. You're the co-CEO of the Luala Community Alliance based in Kenya. And I know that you experience and deal with pneumonia regularly at the Luala Community Hospital and more widely in the community. What was that moment for you?
Good morning and good afternoon, everyone. Thanks, Anuba, for this opportunity. Right, you know, it's easy to talk about statistics around pneumonia, acknowledging the fact that, you know, pneumonia accounts for over 21% of under 5 deaths in Kenya, and that Kenya as a country is among the 15 countries in the world with highest burden of pneumonia. But, you know, at that it still looks or sounds very mythical. I remember it is this year that I came close to the difficulty of pneumonia. My mom, who is about 86 years old, fell very ill in April of this year. And as it would be for anybody living in rural Kenya, the first point of recourse is to go to your nearest chemist to get over-the-counter medication. You might think of, oh, this is malaria, or this is just one of the fevers. And she did that. And then after that, she wasn't improving and was taken to the next health facility and was given medication. And she wasn't even improving then. It took like a whole 10 days of guesswork or trying different treatments when she eventually got hospitalized. And even after getting hospitalized, she stayed in hospital for 10 days receiving treatment. Now, the unfortunate thing is that much as we knew that she was being treated for acute pneumonia, we could not tell for certain whether this was COVID or COVID-related given her age because of the inability to test. And if anything could have happened to her, or she was in a position where she would expose everyone else to danger for the lack of ability to test and all that. And so I looked at that because she lives in another part of the country or part of the region away from where we work in Luala. And I said, like, if we were in the neighborhood of the Luala Community Hospital, probably she could have gotten a COVID test as the first thing, as a first point of reference. In the course of her treatment, she could have gotten access to oxygen and oxygen therapy, because I kept on asking clinicians, why are you not testing for oxygen saturation? If she's feeling tired, why are you not using even a basic pulse oximeter to determine whether she needs oxygen therapy or not? So anyhow, I think it just highlighted to me the lack of access to treatment, lack of access to diagnostics, and even lack of access to supplementary oxygen that we often take for granted. And I think I just felt so grateful for the fact that with partnerships that we have with a number of you in AIDN, that we can be able to provide life-saving treatment at the Luala Community Hospital, and to be able to do simple things like, testing for under fives, using pulse oximeters, availing oxygen, and more so in the context of COVID-19, that we can have some form of response. Thank you.
Wow, Julius, that's an incredibly powerful way to start us off. And I'm really glad to hear that your mother is doing well. Mani, you lead the equipment program at the DAC Foundation, a private family foundation, and even pre-pandemic were involved in looking for ways to provide oxygen access to community. What was your light bulb moment?
Well, DAC started working with oxygen concentrators around 10 years ago. And this was around the same time that I started working on the program side of the foundation. And I guess I would say that I have two pivotal moments, though I'm kind of lucky that it isn't a situation directly like Julius with pneumonia or with COVID. The first pivotal moment was where we replaced an oxygen concentrator for a very remote hospital in Papua New Guinea called Kapuna Hospital. It was hand carried by a series of volunteers, and it kind of went on a boat, on a courier, on a truck, and on a plane. And PNG just has the most overwhelmed health system, and there's a lot of broken supply lines. So the concentrator to us seemed like this magic, oxygen, medicine, life-saving device. But the second pivotal moment was when it was more of a crescendo, really. Over the following 12 months, we discovered that the supplier had mistakenly told us that it was maintenance free. And a lot of the talk today will be about maintenance. And so we then went down a rabbit hole for 12 months and have been going on the whole time to really find out what kind of support is needed for oxygen systems.
Yeah, thanks, Mani. We'll unpack some of that detail later on in the webinar. Roger, fun fact, you were born in Uganda at Vidika Hospital in Fort Portal, am I correct?
You are correct. Well, for anybody listening, I had no idea that question was coming because I was ready to answer the other question. Go ahead, Anuba.
Well, yeah. and you're a physicist and you work in the depths of the physics department at the University of Melbourne. Yeah. What made you pivot and focus your work on tackling pneumonia via FreeO2?
Well, I think the question is what made our team pivot. And so I'm one of the co-founders, but Bryn Sobbett, one of our other co-founders, we had been working closely with our colleagues in global health, but we come from a background of physics where we're developing little gizmos that scan for blood hemoglobin, whatever. Bryn went to a seminar held at the Nossel Institute and came back home excited and upset, came back to the lab excited and upset. And it was that was the first time, I think 2011, 2010, where we became aware of the burden of pneumonia. And at that time there, we were made aware of the fact that almost 1 million children were dying and that oxygen played such a vital role in their treatment. And we were faced with a minor dilemma because Bryn and David and myself were all paid to work on big physics experiments. And so in our spare time, we thought, well, how can the medicine be in the air around people, around these people who need it, and they don't have access to it? And yet here we are in our cathedrals of physics and we have liquid oxygen and liquid helium and whatever. And so that started us on the journey. So that was the pivotal moment. And then there were humbling moments. And Julius, I'm so glad to hear the positive story, with your mother. There've been other humbling moments where we've witnessed the tyranny of the lack of oxygen, and that's kept us on this journey. And so 302 has been on a journey to understand how we can assist to get more oxygen to where it's needed, so that what we take for granted can be assumed for people right around the world.
Yeah, thanks, Roger. And we'll talk a little bit more about your work later on. Leith, you're joining us from New York, where it's close to midnight. Thank you so much for making the time to join us here in Australia. Tough question for me to ask you, as you know, I see you as the guru on oxygen. You're the coordinator of the Every Breath Counts Coalition, and you've kept the global community on its toes with weekly calls trying to address these critical issues. Do you have one pivotal moment you can share with us? I imagine you'd have several such moments.
A lot of moments in the last 2 years since it really hit in March 2020. And I'm going to show you one in a minute, but really it's the images, and we have to thank the journalists for this. It's the images that started exploding in the media from maybe summertime last year of family members lined up trying to get oxygen. It started in Latin America, then it spread to Asia, Middle East, and Africa. These long lines, I'm sure many in the audience will recall images of family members just waiting, sometimes overnight, to get oxygen to take back home to a loved one who's struggling to breathe. And what went through my mind is I put myself in their position. What if I had a mother or a child or a partner at home dependent on me getting that oxygen filled, and I'm standing there, night is falling, and there's a line a mile long. I mean, the agony of that position, and there have been hundreds of thousands, maybe millions of people in that position in the last 2 years.
Yeah, most definitely. The last 18 months have been a dramatic eye-opener, I think, in the lack of access to oxygen. Thanks, everybody, for sharing those insightful and impactful moments and starting us off with a bang. Leith, you've just released a report called The Missing Piece: Why the Global Pandemic is an Inflection Point for Pneumonia Control. We'll share the link in the chat box in a minute, and I encourage everybody to have a read. But can you share with us some of the key points from that report?
Would you like me to show you a few of the images now?
Yes, please.
So here is one of the images that I mentioned before. This is from Peru, and it was taken in February this year. We don't know if this is a man or a woman. This person is not dead. They're sleeping, they're resting. They have their oxygen cylinder behind them in line, and they're just waiting to have that filled to take it home. I always start with this image because we'll share a lot of numbers and statistics on this call, but at the end of the day, the work that we're all trying to do is for that individual lying there in a desperate situation, something that never should have happened, but something that has happened over and over again in the last 2 years. So how did we get to this point? And the theme of this webinar is the double burden of pneumonia. What is the double burden of pneumonia? So if you look here, this is in the blue graph is pneumonia prior to COVID. It was already, as Anuba has said, the leading infectious killer of all people, 2.5 million deaths. Then you add COVID onto that, and that's the orange bar. And you're adding another 3.6 million, we think, deaths in 2021. So the overall burden now of respiratory infection is up over 6 million. Compare that to the other leading infectious killers. Diarrhea is number 2, 1.5 roughly million. And then tuberculosis, HIV, AIDS, and malaria. We hear a lot about particularly these 3. Now, after COVID, nothing comes close to respiratory infections, pneumonia, as a cause of death. You can see from this chart. So this is something I think the world still doesn't fully understand, just how large the burden of deaths from respiratory infection are. When you drill into countries, there's many countries now who also have a double burden of pneumonia from COVID and non-COVID causes. And these are the countries worst affected at this point in time. These are the countries where they have a large annual burden of pneumonia death from non-COVID causes, that's the blue bar, and then from COVID, that's the orange. You can imagine the health systems in these countries, because all these patients, when they get very sick, need the same things. They need pulse oximetry and oxygen, as well as other medicines. So the health systems are completely overwhelmed at this point, particularly in these countries. Just how high has the need for oxygen gone during the pandemic? This is a tool we built and launched about this time last year. You can find it online. It's called the COVID-19 Oxygen Needs Tracker. And it measures the daily need for oxygen across all lower middle income countries. So when we began, each day, all lower middle income countries needed about 7.5 million cubic meters of oxygen. The peak you see, the big white mountain around May this year, is what happened in India and Nepal, which I'm sure made it to the Australian media. The horrific images of patients in India and then afterwards Nepal trying to get oxygen. Many people died during that wave because they couldn't get oxygen. Now we're coming down again now, but with this virus, who knows? In the next 2 or 3 months, we could see another wave peaking in another part of the world. We just don't know what's going to happen next. But at this point in time, we put this map out every week, we update it. These are the countries, there are 33 countries at the moment at risk of oxygen shortages. We color code them, so the red ones are code red, they are at highest risk. The yellow ones are at a lower risk and the green ones are still at risk, but they're coming out of a surge scenario. So we put this out into the world so people can target the support to the countries where most lives are at stake. But we always have to remind everyone that COVID-19 is just the tip of the iceberg in terms of oxygen need. As big as that need is, there's this hidden underlying need that's never been met for oxygen from non-COVID patients. Lots of children with pneumonia, lots of newborns, and lots of adults with infectious diseases as well as chronic diseases like COPD. This need is still unmet. And even when COVID goes, hopefully soon, we will still have this underlying unmet need that we will have to meet. So my question for you today is, are we prepared? We are not prepared, particularly because all signs point to us having entered an era where respiratory pandemics will continue to occur. And there are some of the factors that are occurring. So what do we need to do? We need to invest more in oxygen. And I'm very pleased to be on the webinar today because we really want to issue a special call to the Australian government to step up and invest more in oxygen. And today we're calling on the government particularly to invest $50 million US dollars in the international oxygen response. We've written to Foreign Minister Payne and to the Department of Foreign Affairs and Trade. We think Australia is particularly well placed to lead on oxygen, given all the expertise in the country. We'll hear from some of it today, but there are others. And the fact that Australia is one of the few nations in the global south that hasn't had an oxygen crisis. So you're well positioned to support neighbours. So let me conclude there and return the screen.
Yeah, thanks very much for that very sobering and urgent context, Leith. I know that on the Every Breath call, Every Breath Counts calls every week, that chart of double burdens kept moving. And when the surge in India and Nepal was happening, you could see the need rising dramatically, and you know, multilaterals, donors, everybody jumping to support. So that it's been really good to kind of see that on a weekly basis and that movement. So I think I could see a question on the chat asking about low identified demand in Africa, and I think, Leith, you can answer that by just the movement of the cases in the countries, depending on surges. Is that right?
Well, Africa is not counting. So the WHO, I think, said a week or two ago, only 1 in 7 COVID cases is being counted in Africa. That's their estimate. So there's a lot of cases not being counted, a lot of unmet need. That's certainly true. There's also something else happening that we don't fully understand, and it could be to do with the younger age profile of the African population. They have fewer older older people. I'd love Julius's comment on this in a minute. But really the balance of opinion is we're not quite sure if we're not seeing the COVID cases in Africa or if there is lower transmission because of a younger age profile or perhaps other factors we don't fully understand yet.
Yes, that's right. And
Yeah.
Roger, you're right. Lack of data from Tanzania, for example, but Julius, over to you.
Right. The first thing is that we should understand that there is very little testing going on. And if there is little testing going on, it means that you would not be able to find the cases and also report the facts. So there is a lot of underreporting. There is a lot of, symptomatic diagnosis that is going on or diagnosis by observation that is going on. And some of the cases that actually go untreated probably end up not being reported. Cases that go treated but without testing go on being underreported. But the other thing that I've also seen is also the difficulty of choice between the statistics around COVID and the harsh economic realities. And governments are hard pressed to balance what it would take to institute public health measures. We know that that has been very hurtful for a number of our economies. And so I think there is a bit of underplaying or downplaying the gravity of the problem. And so might speak to some of the statistics that we see here.
Yeah. Julius, one of the things that I wanted to, kind of talk to you about is Leith has set this picture for us at the macro level, but you work at that community level, at that micro level, and you see it very much on a daily basis in the community. That first image that Leith shared is so powerful and really brings home that point of the devastating impact that COVID has had at that community level. How does all of this translate into the work that you do at the community? How are you tackling the situation of pneumonia and COVID at Luala, for example?
Like it was observed in the presentation that Leith has just made, it's obvious that even prior to COVID, pneumonia was already one of the leading causes of morbidity and mortality in children under 5 and the general population. And we know that part of this is because of the transmission that is very possible from indoor cooking with firewood that leads to a lot of infections and upper respiratory tract infections. And that means that in a small area or in a rural clinic like where we operate, most number of cases that end up being treated is actually upper respiratory tract infections. But that also goes on with confirmed clinical pneumonia. But we should also know that pneumonia is so hard to diagnose. And that means that we could, even in the numbers that we are counting, probably we are underestimating the true numbers of pneumonia cases in areas like ours, because other than respiratory RR rates that clinicians use, you then want to go into things like x-rays and sputum tests and all that, which are not available in low resource settings like ours. So the advent of pneumonia, of COVID actually has just accentuated the problem that we have. And if you saw the spike or the mountain that was shared, that also coincided with the increase in number of cases that we had in Luala and Migori and in the region, where the Delta variant actually was detected in Western Kenya. And for the first time, we saw fatalities from COVID on our doors. But I think the response that we've had is to look at both community level responses. We work with community health workers. These are lay health workers that are trained and equipped to be able to provide care in the homes. So these community health workers, courtesy of support from partners like DAC, we've been able to get finger oximeters that they are using now to be able to help better diagnose cases of pneumonia. And with the improved or revised guidelines on ICCM, then these community health workers are able to use dispersible amoxicillin as a first-line treatment for pneumonia before they refer to the health facilities. What that does is that, on the one hand, we are able to treat cases faster before complications that arise with pneumonia, and then also reduce the burden that health facilities have to face because of conditions that can be managed at home. We know that the progression of pneumonia is very quick. And I remember earlier on in my career when I worked with an Australian bush doctor in the informal settlements of Nairobi. His assumption was that if you get an abnormal RR rate, treat for pneumonia and ask questions later. Because if you do not do that, 6 hours down the line, that child would be in a condition that they are not helpable. So I think just knowing that we can have appropriate responses and quicker responses to treatment, that gives higher chances of child survival and all that. And then with COVID, we've been lucky to be able to test for COVID using rapid diagnostic test kits. Initially, government was very hesitant to allow use of RDTs, and instead opted for the PCR test, which could only be done in a couple of regional laboratories that took very long to get results. But with approval of the rapid test kits, we've been able to make those tests more quickly available and all that. But most importantly is the partnership that we have developed to be able to get oxygen on site as a first line treatment for uncomplicated cases. So the donation or the support that we've gotten for oxygen concentrators, but also oxygen cylinders that can be delivered and be deployed with patients at the local level has been very useful. I think generally oxygen is underinvested in. I think COVID has done raised awareness or consciousness on the importance of medical oxygen. For a long time, I think it's an area that people thought it's auxiliary to the health system and auxiliary to management of conditions. But I think this treatment and the case that COVID has provided can raise awareness among healthcare practitioners and policymakers to think or rethink about medical oxygen and how this can be deployed in low resource settings like ours. So whether it is bottled, like what we have with cases where you have plants and then cylinders can be delivered to facilities, whether it's supplemental from oxygen concentrators and all that, to just heighten the need that medical oxygen is actually an essential commodity, and that which needs to be availed for every health facility that is available. And so I join my colleagues and panelists in making this call to action to think about medical oxygen and availability of oxygen as a critical care item that needs to be a basic care item that actually needs to be done at primary healthcare facilities. Thank you, Anuba.
Definitely, Julius. I think you bring that urgent attention to the importance of investing at the health system level in all aspects, not just equipment, but testing, diagnostics, medication, all of that, that needs to be a part of ensuring uninterrupted and equitable oxygen access to patients. To add to this, Liz, you shared a very distressing story on the Every Breath Counts call last week, the story of Matato from Malawi, a biomedical engineer, and his fight for getting oxygen for his uncle. I wondered if you wouldn't mind sharing this story with us in a couple of minutes.
Yes, so Matato Sinjani is a young technician. He actually has expertise in oxygen in Malawi, and he told us this story, and we have his permission to share it. It's a very personal story about how he lost a family member, his uncle, because of a series of mishaps. The oxygen was there, but a lot of other things were not. And his uncle unfortunately passed away. But he got a call, this is July this year, and he got a call from his aunt saying his uncle was very sick and in hospital. Matato rushed to the hospital, a big hospital in Lilongwe, the capital of Malawi. to find his uncle desaturating. So his oxygen levels were falling. And so he decided, well, we'll put two concentrators together and try and get more oxygen for my uncle. So to join two oxygen concentrators together, he needed a special connector, which the hospital didn't have. So Matato had to leave the hospital, go back to his workshop, where luckily he had one. And he went back to the hospital and fitted everything out. And he thought that was going to be fine. He left for the evening. He came back Sunday morning to find his uncle's oxygen levels were falling again. It was a Sunday, so very few doctors were on the ward. The concentrator had been removed. There was only one. The nurse had to take the second and give it to another patient. But there were oxygen cylinders lined up, so he could get one of those. But to get one of those, you need the guy that has the spanners to change some of the flow meter and the regulator. Okay, that guy was there. They changed it. Everything's good. His uncle gets some oxygen cylinder, oxygen, and he's coming back. Matato takes a break and comes back and finds that oxygen cylinder is now empty and his uncle is desaturating again. He turns to get the spanner guy to change a new tank, and the spanner guy can't be found. So Matato, all he needs is a 28 millimeter spanner, and he has the skills to do it himself to fix the problem, but the hospital doesn't have a 28 millimeter spanner. Matato has to leave again, back to the workshop to get the spanner. He meets one of his colleagues halfway to save time, gets the spanner, races back to the hospital, is in the elevator doors open, and he hears his aunt crying. And of course, he knows what's happened, but he has that 28 millimeter spanner in his head. He's nearly there, but it's too late. His uncle passed, and Matato describes looking at that spanner and revisiting in his head the last 48 hours. He tried everything he could to get oxygen to his uncle, and he had the skills to do it. And still, the obstacles were insurmountable. He tells that story because he knows he's not alone, and that is happening in way too many places. Right now, as we speak, that story in some way, shape or form will be playing out.
Absolutely, Leith. It's just a heartbreaking story. This is the third time I've heard it, and it's still, it's heartbreaking, and it encapsulates all the things that need to be done. We really pass on our condolences to Matato and his family. Matato has given us permission to share this story, and it will be published next week. And just like Leith said, recognizing that this is one story of many, 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 and he had the skills. He was one of the better ones in being able to access the spanner man. So I think just there are really two parts to this story and to Julius's commentary. And, there's a question in the chat about whether this is a global issue or a local problem or both, and what are the bottlenecks. And I think that's kind of well placed to kind of go into kind of divvying up like two parts to all of the work that happens at the community level. Part A is, how do we tackle this enormous issue on lack of access to equipment and everything else that comes with it? Mani, I'm going to ask for your comments on this one. And part B, how do we make it easier to access oxygen in health systems that are clearly already struggling and overwhelmed? Roger, I'll come to you for your comments on that one. Mani, you've had years of experience around medical equipment distribution to countries far and wide, and have had the ability to be nimble and flexible in supporting the community needs around oxygen. What has DAC Foundation's experience around this distribution of equipment been, and what are some of the issues that you've had to tackle at that little nitty-gritty level?
Okay, thanks, Anuba, and Leith, thanks for sharing Matato's story. It's a really tragic illustration of the gaps in healthcare systems in low resource settings. You can have dedicated people and knowledgeable, skilled people, and you just still have roadblocks. So we've seen the same spanner man situation play out before in a newborn unit in Uganda, after the nurse discovered that the concentrator was only producing 30% purity of oxygen, which is just pumping room air essentially. However, in that situation, they had both the cylinder and they found the spanner man. So it had a better outcome. For DAC Foundation, we learned early on in the piece that the technical management of oxygen equipment is almost, not quite, but almost as important as the clinical management of the patient when they're low in their saturations. Many of those lessons came from our collaboration with Murdoch Children's Research Institute on fairly large interventions in countries like Nigeria, in Papua New Guinea, and most significantly in Laos, where we helped out with putting in oxygen into 120 district hospitals. Pre-pandemic, the fundamental issues seemed to us that it was access to oxygen. COVID hit and the landscape changed a lot, and it changed again when Delta variant came out. Africa in particular seemed to be flooded with bedside concentrators in 2020. Didn't solve the access, but there were a lot of concentrators out there. The big agencies really made huge efforts in the emergency response. But in the scramble, there was no time to address what was really needed to keep that device functioning, because it's not just access to power. Then there's power outages and fluctuations that are so common that you have to have voltage stabilization. You need to protect the circuit board from blowing. You need preventative maintenance, cleaning the filters, checking the pressure, checking the purity. You need the device and the tools to check that purity, like an oxygen analyzer. The issue is no longer access to oxygen, it's about sustainable access to safe oxygen. And those who have been working in this space for a while could see those gaps, but moving from emergency response into a sustainable ecosystems is a huge gear shift. Luckily, there are some small and medium-sized organisations, including DAC, who look for the gaps and try to connect dots where we can. I'd like to highlight two of our partner programs that I think really illustrate the impact and efficiency in filling those gaps. The first is Open O2 in Malawi, whom we met via the Every Breath Counts Coalition. The co-founders are biomedical IT specialists. One is from Malawi, one American. I can see that Timothy Matonga is on the call from Malawi, so hi, Timothy.
Hi, Timothy.
They set up a small health innovation hub with just a few volunteer staff. But when the oxygen crisis hit in 2020, they knuckled down and looked at what they could do to help. They figured the quickest thing was to repair the country's many broken oxygen concentrators. And then they honed in on the two most common failure points, the lowest hanging fruit, which we love at TAC, and then they focused their program on fixing those two things. They fundraised from friends and family, they bought a secondhand van, turned it into a mobile workshop. DAC provided their first in-country general funding. It was flexible, it could cover salaries and consumables. Now they've fixed over 600 oxygen concentrators and counting. But what that means is for about $100,000, they've repaired concentrators that produce around $5 million worth of oxygen. And so we'll drop the stats into the chat box. It's just the most incredible bang for buck. And Mateto is one of the amazing members of the Open O2 team. So Open O2 are now working on ideas to create and strengthen the supply chains for spare parts, which is a huge issue. And we love that grassroots organisations are working on those ideas. So kudos to them. At the other end of our kind of collaboration spectrum is in Mali with an organisation called Muso. In 2019, we supported an oxygen pilot in their 9 clinics, 1 referral hospital, and their motorbike ambulances with a mix of cylinders and concentrators. Muso trained their staff in how to clinically manage pneumonia and how to manage low oxygen levels in patients. They set up protocols on preventative maintenance for the oxygen equipment. Muso had already been providing technical advice to the government on community health worker programs. That's their main gig. So when COVID hit, they were perfectly positioned to advise government on oxygen systems. So they went ahead, they designed and implemented a national training schedule across 50 district hospitals, which expanded on the 2019 pilot. Critically, this program included really comprehensive training for the lead biomedical engineers from each region, as well as a tiered hands-on training sessions for staff at every single hospital, which is huge in Mali. It's a hard country to get around. DAC Foundation donated the full suite of equipment for that program. There was a concentrator and pulse oximeters, voltage stabilizers, nasal cannula, resuscitation kits, training materials, oxygen analyzers. Anuba warned me about going into too much detail here, but I kind of just want to illustrate there's a whole lot of little things as well as all the tools that are needed.
Absolutely.
But then Muso discovered that another 150 oxygen concentrators had also arrived from another donor. Again, this is part of emergency response. It arrived with no accessories, no biomedical training plan. luckily, Muso and DAC could just kind of fill in those gaps with our equipment and our training plan. So those two programs show that funding that can be both focused and flexible can have this huge impact, even if the dollar value itself isn't massive.
Mani, thanks for that excellent summary. The examples you shared, are obviously wonderful examples of how things work when you kind of look into the small things that need to be done and really showcase that flexible donor funding to fill the gaps left by other donors, even if it's unintentional. It's a really powerful way to create a massive return on investment. This is also the perfect time to segue to Roger, to go to part B, to try and answer that question. How do we make it easier to access oxygen in health systems that are already struggling and overwhelmed? 302 have been working in that innovation space and are doing some fabulous work in Uganda. Can you give us some insights and details into your work?
Thanks, Anuba, and thank you, everybody. You've set the scene. So I'm going to change it ever so slightly because
you're Roger.
Well, I mean, I want you to imagine four eyes, I. People like us, scientists and engineers, I'll bring the engineers into there. We come up with ideas all the time, all the time. But those ideas are worth nothing until you innovate them and do something useful with it. And that innovation is still not useful until you implement it, because you have to get out there into the field. And the measure of how good anything like this is what is the impact. And what we've heard from Mani just talking, what amazing impact a little bit of knowledge and training could actually have, because that's the measure. And Mani, you don't have to worry because the devil's in the detail. The second thing, I know I'd like to put forward the question. There must be Australian health workers on this call. I guarantee you, none of them know where the oxygen comes from in the facility where they work. None of them know about half of these things we're talking about because they're trained to treat people. They're not trained to deal with equipment. And so wouldn't it be nice if the health workers in sub-Saharan Africa, in India, in Asia, in Timor-Leste, in PNG, could focus on what they've been trained to do and have other people worry about it? So I'm not going to tell you how excellent 302 is. We are the only group in the world who can produce oxygen with no electricity, right at the end of the line, right in a tiny little village of Bugoye near the Congo border in Western Africa. We've done it. So if we can do it with no electricity, imagine what we can do with some electricity. And Mani, you've spoken about power stabilization and all these things. Forget about that. What the health worker needs is a tap on the wall behind them where they turn it on, and Julius's uncle gets oxygen. The same with Matato's, Julius's mother, Matato's uncle. They get oxygen and the health worker can focus on them. So what 302 is pioneering is oxygen as a service, backed up by technology, backed up by know-how, and creating an enterprise where local people can take responsibility for delivering oxygen and providing oxygen. The costs are incurred locally. It's not a free service, but it is an appropriately priced fee service to actually support the operation of that model. Separate to that, we've abstracted the capital equipment and we rely on donors to actually offset those costs. Now, the donors get the benefit because with the maintenance, we get longevity in the equipment and there's value in that donation. But then there's a fundamental underlying problem. I'll go back to those four eyes, because all of the equipment that we're talking about, the 150 concentrators that arrived from the very generous donor, they're all domestic pieces of equipment that have been built for highly Western advanced nations. They are not appropriate for low resource settings. And so what 302 has done over the last 7 years is work closely with manufacturers and prepare for transition to develop an appropriate and affordable oxygen system for use in LMIC. And the target is to actually manufacture that device. And that involves technology transfer, in this case from Australia, from Germany, from America, into these very able young biomedical engineers and empower them to actually take responsibility and deliver it. So that's our model. It's really, really straightforward. After that initial time where we first became aware, and we spent many years understanding the problem and sharing the problem with many people on this call, we finally now have a solution which actually allows that to happen, where the nurse and the health worker can actually focus on treating the patient. If the power fails, it automatically kicks in. If the backup systems run out, it automatically actually switches to a backup without them intervening. And then we harness technology, because all of our systems are monitored in real time, and you have the information. Believe it or not, I've been in these facilities, Julius knows, where you may not have oxygen, but your mobile phone works. And so we actually deliver real-time information on all of our systems to the biomedical technicians so that they can actually take care of it. And so ideally, with vaccines, you protect people. With change in lifestyle and cooking, you prevent the illness. And with oxygen, you treat. The other two are long-term, the immediate response you get from treating people with oxygen, and that's what they need.
That's great, Roger. That's, you've also, for you to have just won an award for the rollout of your program in Tanzania in collaboration with UNICEF and is it Oxygen Cola?
That's right. So through
can you tell us a bit about that?
Yes. So we are piloting now. So we've been working in Uganda, but there's no sense developing something that only works in Uganda. So we're going to take the learnings from Uganda and in the next 6 months roll out to another 20 or 18 health facilities in Tanzania, but not in central, not near the big cities, Dar es Salaam or Arusha, but in the periphery where the mortality occurs. So in the Mbulu district, all the way from Arusha down through to Dongabesh, we have 18 health facilities, which typically cater for about 30 or 40,000 people. They typically need to support about 200 or 300 children in their pediatric wards, several hundred maternal requirements. We will be providing each of these with an oxygen system, and the oxygen is a service. And so they will pay a small monthly fee. And in that, we will actually train locals. And that's actually another important point we've learned. We don't need to train biomedical engineers. We can train electricians and motorcycle mechanics to actually take care of this equipment. And it therefore becomes affordable. So thanks, Anuba, for mentioning that. Yeah.
What's going to be your biggest challenge, Roger, to roll this out in Tanzania? You've got a plan, you've got a system, it works. What's going to be the thing that derails it?
Well, I'm sure UNICEF are listening, so we're not going to have any challenges whatsoever. There's just the tyranny of distance. The lockdown has meant that we have to plan remotely, but we've been able to do it. I think the biggest challenge we will face is how do we deal with the fact that there is insufficient resource in the form of money to actually pay for the oxygen service. So the biggest challenge we're going to face is how do we actually make it sustainable to pay for that service. I don't believe we face technical issues. We've actually dealt with all the technical issues. And the success will be, can we make it sustainable?
Yeah, that is a big question, isn't it? Mani, you might want to comment on this because we've been working with DPRISE, and maybe you can talk a little bit to the oxygen concentrator maintenance challenge and that exact issue that Roger's talking about, the payment of service for servicing an oxygen concentrator and some of the learnings that are kind of early learnings that are coming out of that prize.
Yeah, so we collaborated with DPRISE, who they're a US-based group who provide seed funding to social entrepreneurs who design businesses that solve distribution issues, I think you'd call it, for proven poverty interventions like family planning or solar lights. In this instance, they did a prize, and the distribution issue was the maintenance of oxygen concentrators. And so they've got the prize running, but there's been 3 prize winners so far. I believe one was from Ghana, one from Uganda, and one from Nigeria. And each of them face different problems depending on where they are. So in Nigeria, we found, having this as a program in a capital city is not relevant because they're very well supported with oxygen plants at the hospitals they were targeting, whereas some of the other programs were extremely successful. So that's one learning. That also kind of leans towards the question that we've been asked about what are the global issues and what are the local issues, which we can dig into a little bit later. But D-Prize is one of these organisations that is funding something flexibly, and what these social entrepreneurs are doing are doing things like Roger's alluded to. They're not sending biomeds out just for this or for that. They're trying to build a sustainable business. Because that's the only way forward. There's some countries where I think it's just going to take a lot longer than other countries. I'm probably speaking a little bit too much, but can I talk about the NCOMA project very quickly? So for example, there's a great model that they have in Kenya, which is done by Huey, which is an oxygen plant, with a social, an ethical for-profit. And what they do is that they do a milkman delivery of oxygen, and they do it at a fairly subsidized price, which drove the price down for other oxygen manufacturers in Kenya. But the milkman delivery is the key thing, because we get oxygen delivered in cylinders, like Roger has said. It's just, magically happens for rural communities. But most countries that we deal with, you have to send someone to go pick it up and then wait for it to be filled, then bring it back. And that's a huge loss of staff time. So the milkman delivery is just a great idea. We're funding a program in Malawi where African Mission for Healthcare is building an oxygen plant at NCOMA Hospital. And what we're doing is going to bolt on this service, which is the milkman delivery of oxygen cylinders. But there's no money that we tried to look at whether it could be sustainable after 5 years. And we figured out, no, it's probably, they'll never be able to pay for the oxygen in that time frame. So the good situation we had was that the hospital is actually growing. They're going to need all of the oxygen from the plant within 5 years. So, win-win outcome. Yeah.
Julius, I just kind of want to go to you. Sorry, Roger, one moment. In terms of oxygen access, what you're seeing in the community, do you think there's going to be a moment in Kenya where you think, oh, you have enough oxygen, you're okay? Because I know you get some of the cylinders from the Hewateli plant to the hospital, and that's been a nice way for you to kind of have some sort of sustainable and regular access to oxygen. Do you think there's ever going to be a time?
Wow. Is there going to be a time when pneumonia and need for oxygen will decline? Not sure. I think the need will just get heightened. And I think innovations like what Roger has described, by the way, I'm taking you on that, because I think we're looking for the biggest challenge in accessing oxygen is the issue of power. And whether you're looking at a concentrator or a mini oxygen plant and all that, the amount of power required to generate oxygen, I think, is the biggest barrier that many places and many rural facilities like ours face. So the need will increase. I think what we should be talking about is how do we meet that need sustainably and make oxygen more available to people, because it's not reaching the people that need to reach it. We use Hewateli, and they've been a great partner in helping us, design and include like piping of oxygen to a few beds so that it's available for the nurse without asking where this is coming from. And we dream of that future where healthcare workers actually can be in a position where they can be focusing on their work. The nurse doesn't need to know about where the oxygen is coming from, but to concentrate on the patient. And I think that these dreams are valid, they are achievable. And I think somebody asked, like, what is the place that the government can play in ensuring that this is a reality? I think that philanthropy has done its part and is doing its part in catalyzing and moving things faster. But I think a health systems solution is required, where we're talking to governments and making governments prioritize oxygen as something that needs to be. And so what we've seen in Kenya, for example, is where with the decentralization of health services, a number of counties are trying to set up oxygen plants on their own. Sometimes the production capacity is not sufficient to go beyond the referral hospitals, but I think that is a good first step for ensuring that actually there can be a refill plant. The Hewateli plant, for example, is more than 150 miles away from where we are. So it's been helpful that the county government set up a plant, and however low capacity it has, we can actually be able to refill the cylinders 50 kilometers away. But again, you look at the cost involved of transportation and all that. And if there can be local solutions, facility-based solutions that are available, that would be great. I know we are short on time, but I think with this, I would just say that, you know, the world seems to be moving ahead and thinking that the worst of COVID-19 is past. But I think the reality that we have on the continent is that there is so much that needs to be done if this virus is not to reincarnate, because it might come back again in another form because of lack of access to vaccination and all that. And we'll just rubbish every effort that has been made in increasing vaccine access and making other parts of the world safe. So my call is, let's not leave Africa behind, even as we make it.
Absolutely not. Leith, just a quick comment from you on what roles government can play. You know, you're kind of on the pulse of it in New York. You know, the missing peace report has been tabled at the COP26 and the G20 summits. What role can governments play in, you know, in urgently seeking to address this issue?
Yeah, I agree with Julius. At the end of the day, it's the government's responsibility to provide healthcare for its people. So the government has to be in the driver's seat, but they can't be alone. In many countries, particularly the lowest income, they just don't have the financing to do what needs to be done. So those governments need support from global health agencies. There are many global health agencies that provide support to governments. They just haven't been doing it for oxygen until the pandemic. This is the big thing that's changed. We now have the Global Fund, which used to only focus on HIV, AIDS, TB, and malaria. It's funding oxygen for many countries. We have the WHO and UNICEF doing more in oxygen than they've ever done. And we have all the private philanthropies like the Gates Foundation and many others now fully engaged. I very much agree with Julius. This is not over. We need to be on full alert. We do not know what this virus may do, and we need to keep going with oxygen. I describe the vaccine-oxygen relationship like a seesaw. All the while the vaccines are low, which they certainly are in Africa, our treatment needs to be high, because when people get sick, and they will, they're not vaccinated, that's all they have is a fast diagnosis and effective treatment. So all the while those vaccine numbers are low, we need to be full throttle on oxygen support. So we are just charging forward and continuing to do it. I have to say one more thing before you move on for this Australian audience. Australians are punching way above their weight in the international oxygen response. You've just heard from a handful of Australians, DAC, Frio2. There are others in the audience. I see Adara here who work on newborn oxygen, and there are more. Dr. Hamish Graham, Professor Duke, I could go on and on. Australia is a centre of oxygen excellence, from research right through to implementation. Please ask your government to step up and support these efforts, because Australia could be a leader in the international oxygen response. You have what it takes, but you will need to apply pressure.
Absolutely. Big call out to the Australian government that $50 million is required urgently towards oxygen access. Roger, last comment from you. What's your call to action and how better to support innovation and implementation in the field?
It's really easy. Buy one, get one free. Every time we use oxygen, think of those that don't have oxygen, and let's donate that same amount of oxygen to the rest of the world. If we equipped the rest of the world with the amount of oxygen we need, there would be no need for a discussion here. The very thing is, it's got to be cheap, and oxygen made by remote systems is cheaper than oxygen being distributed by cylinders. And so we've got to just get a distributive model. And a shout out to the guys from Centox who are also on the call here too. Yeah. So.
Yeah, I'm sorry, I can't get to any more questions. We've come to the end of this very engaging and detailed conversation. Thank you to all of our panelists, from good morning in Kenya to good night, Leith, in New York. Thank you all, audience, for being a part of this webinar. A recording of this session will be on the AIDN's YouTube channel over the next 24 hours. And we'll send an email out to everyone who's registered with key points and the calls to action. AIDN has also released an episode this week of their podcast, Philanthropod, featuring Roger. So I encourage you to check that out on Spotify and the Apple Podcasts. Thank you all so much for joining us today. This has been an incredible pleasure for me to host this. Thank you very much.
Thanks,
Thank you.
Anuba. Thank you.